Dr. Jones is board-certified family medicine physician through the National Osteopathic Board of Medical Examiners. Dr. Jones earned her medical degree from the University of Medicine and Dentistry, New Jersey, School of Osteopathic Medicine, and holds a Master's of Public Health from Dartmouth. She brings with her a prolific portfolio of publications and presentations. That was alliterative. Her leadership background as a COVID public health officer during her tenure at Cornell University will bolster Rowan Medicine's role leading the way to a healthier nation. Dr. Jones is the Director of Student Affairs at our Rowan SOM Sewell campus and core faculty of our Inspira Rowan SOM Family Medicine Graduate Medical Education Programming. Dr. Jones serves as faculty training medical students in the community service learning and leadership and osteopathic clinical skills curricula and provides patient care at the Rowan Family Medicine Sewell office. Please help me welcome Dr. Ann Jones.
Thank you. Oh, no problem. Thank you so much. I'm excited to be here. I'm also fully aware that I stand between this group and dinner, so hopefully this is efficient and quick, but also fun and exciting. So today we're gonna, I have no disclosures to report today. 3 lecture objectives. The first is to start with some definitions of health disparity and health equity, as well as inequity, and then go into some examples of each, and then end with really a case study of sorts of talking about health equity and just culture through the lens of the COVID-19 experience and COVID vaccination. And when we talk about these subjects about public health and health equity, for me, I think about our identity as osteopathic physicians. And I think about the osteopathic oath, which actually dictates that we should be vigilant in aiding the general welfare of the community. That always spoke to me, that line. Because we of any of the health professions and of any oaths actually have a line empowering us to be stewards of the community's health, and that has always been inspiring, as well to endeavor to work in accord with colleagues of spirit of progressive cooperation and collaboration, and those are key concepts in health equity and in public health. When we think about public health, anyone who's been working in public health may recognize this schematic. It's the socio-ecological model, which was developed in 1991 by Dahlgren and Whitehead. And it talks about the concept of public health being a very complicated and complex set of systems and structures that are all working together towards individual patient health and community health. And when I look at this diagram and when we teach this concept to medical students, it's inspiring too, because it really emphasizes the fact that when we think about complex problems in healthcare and in the world of public health, it isn't just one solution or one example of how we can make our systems better, but there are multiple levels. There are levels at the individual, interpersonal, organizational, community, and policy level that all should be working in concert together for community health. Public health as a science also brings together many interconnected themes. And when we think about working in this space, it brings together themes of medical systems and justice. It asks us as physicians to confront the systems in which we trained and the systems in which we work. When we do that, it causes us to examine the social and behavioral determinants of health that bring our patients into the exam room. When we do that, we then confront the systems of social contexts that cause system issues like structural racism, and it also asks us to confront anti-racism in our practice. When we do that, it asks us to think about the constructs of power and privilege, and then we begin to examine our own implicit bias in order to move towards social justice. So all of these themes connect together in order to have us working at the intersection of clinical medicine and public health. As such, the osteopathic community has really made big statements about the importance of health equity. ACOM, the American Association of Colleges of Osteopathic Medicine, created a pledge across all of the osteopathic medical colleges to confront and address health inequities. As well, the AAMC and the AMA created Centers for Health Justice and Health Equity. And then we even see at the political level and the policy level within our state, this is just from earlier this month, that politicians in New Jersey are advancing legislation to advance health equity and access to care. And then we have Centers for Health Equity coming up at many of the medical colleges that are across the nation. This is Mayo Clinic, Johns Hopkins, Penn Medicine, and Cornell have all created Centers for Health Equity. When we think about health equity, again, I kind of bring it back to it's who we are as osteopathic physicians, that health equity and anti-racism is really inherently osteopathic. And why do we say that? Well, this is a framework that actually went viral last year during the course of the pandemic, when there were episodes of racial violence and police brutality in the midst of the pandemic. And there was a quote that said, the opposite of racism isn't not being racist, it's being anti-racist. What does that mean? It means working toward not just caring for patients, but for dismantling systems that create inequities in our culture. And as osteopathic physicians, we do this. We move from a fear zone, which is when we say, no, these things don't exist, I'd rather not deal with them, into a learning zone, which means I want to ask myself the questions and seek to understand the systems better. The growth zone is where I think we all train and work as osteopathic physicians, which is when we ask questions every day about the patients who we see and how we can make our patients and communities better. So getting into definitions, what is a health inequity? So an inequity is defined as an uneven distribution of social and economic resources that create differences in individual and community health. And the key point is that these differences are avoidable, systematic, measurable, and unjust by definition. This differs from the term health disparity, which has been used for some period of time in the public health word, but really differs in that a health disparity just denotes a difference. A health inequity defines an unjust cause. When we think about health inequities, we link to the social determinants of health, which have been defined by 5 major pillars over time. That is education, access, and quality, healthcare access and quality, neighborhood and the built environment, social and community context, and economic stability. But what research in the public health field has shown over the years is that there really should be more than 5 of those concepts, and that the social constructs of racism, sexism, and other disenfranchisement should be listed among other social and behavioral determinants of health. So research has shown this, and the fields are moving forward. Why do we say that that's important? Is because the research, and these are studies dating back from 2007 to 2014, that show that anywhere from 60 to 80% of health is determined by the social and behavioral factors within a community. And actually, I read a study just this morning from the American Academy of Family Physicians that showed that during the COVID pandemic, at least 80% of health outcomes were due to social and behavioral determinants. That's why this is so important. What are the consequences of health disparities and inequities? Mortality and deaths, which occur. So an example here is Black mothers are 3 times as likely to die during childbirth than white mothers. Mental illness rates rise, and here an example is LGBTQIA+. Youth experience higher levels of bullying and sexual violence. Life expectancy is affected and can be affected even by a location of a zip code, access to health care, and then cost. It's actually estimated that health disparities just on their own cost the healthcare system upwards of $60 billion. So when we think about this in terms of medical education, it comes down to this concept of thinking about health inequities as related to considering racism and race and sexism and these disenfranchisement categories as social constructs rather than biological constructs. And you can see here on the top is a schematic that shows that when we think about these constructs as biological in nature, the studies and the research go about it in that way. Medical education is taught in that way. Clinical practice then moves forward in that way, and we get a perpetuation of racial inequities in practice. Whereas if we think about these issues as social constructs, then we can actually teach our trainees and we can learn in practice how to dismantle the systems that are set up to promote these environments, and then we can actually see a reduction in health inequities in the future. So a couple more definitions: health equality and health equity. For the last probably about a decade plus, the public health community had been using the term health equality. Health equality is defined as an approach that strives to ensure equal assistance to patients or end users, regardless of any other factors. And this is an appropriate approach. However, health equity is now being defined as the way to be. And why is that? Because health equity is an approach to public health that strives to give everyone the best chance at the healthiest possible life, recognizing that some may need more help than others. And rather than making sure that everyone gets equal access, the point is to try to improve and strengthen the kind of supports depending on an individual person. This is an illustration of what this looks like. This is an illustration that many might have seen. On the left is an example of equality, which is when we give a box to every person who is hoping to see the game. Equal access to the box helps some, but not others. Health equity, though, the concept of health equity is by giving more to the people who need more, thereby allowing everybody to see the game. So what does this mean for us as osteopathic physicians? This means that what we do in the exam room is important, but not the only part of patients' lives that are important or the most important. So it's vital to understand these social, behavioral, and environmental aspects of patients' lives. In the exam room, there's two specialists present. There's the patient and there's the physician. And in order for physicians to be most effective, we need to continually learn about our communities and about the social determinants, where our patients live, eat, work, play, pray, and learn. So important this has been that actually the American Osteopathic Association has been putting out information and literature on this topic. This is actually an example of a screening tool just recently put out by the AOA that screens for social and behavioral determinants within the clinical setting. And ICD-10 has actually included Z codes for addressing social and behavioral determinants in the exam room. Now, not all insurance companies are reimbursing, but we would hope that over time, these become factors that can be used in a health technology environment and that help to keep this in mind for physicians who are treating patients. So when we think about our systems of medicine, we think about the fact that these disparities and inequities that we focused on are present, and we accept that there are social constructs in our environment that lead to poor health outcomes. It causes us to take a step back and to recognize that a lot of it comes down to the medical culture in which we live in, work in, and have trained in. This is a really great quote that I appreciate and I think about a lot from one of the fathers of quality improvement, Dr. Paul Batalden. It says that every system is perfectly designed to get the results it gets. So what does that mean? The conversation about medical culture can be dated back to the late 90s, early 2000s, to the two publications on the left, To Err is Human and Crossing the Quality Chasm. These are publications by the Institute of Medicine, now called the National Academy of Medicine. And they were focused on the question of why are medical errors happening in our health system. The research that was done was focused on how do we make errors less common, so wrong side surgery on orthopedic issues, or wrong medication given on the hospital unit. And what the research found was that in most cases, these errors were not happening because of a lack of training, a lack of knowledge, or a lack of goodwill among healthcare professionals who were working. They were happening because of systems issues in hospitals and clinics and in healthcare settings. So it wasn't about there being bad people, it was about a bad system that was setting up good people to make mistakes. And so the other aspect that was found was this recognition that why this exists is because the cultures of medicine, which I think many of us can attest to, is kind of based in a blame or shame or fear culture rather than an improvement-oriented culture or a wellness-oriented culture. And that moves to the third publication on the right, Taking Action Against Clinician Burnout. It's these systems of fear, blame, and shame that lead healthcare professionals to feel burnt out in our work and can infuse its way into the medical systems in which we work. So there are publications that started to speak about this topic, patient safety, not just in terms of how do we make fewer mistakes, but how do we address the culture? How do we look at the ethics that are behind why these mistakes are being made? So we think about this in terms of how does this relate to public health? So we're in our office, we're seeing patients, we see a lot of patients every day. We do our best to treat them. We recognize that there are social and behavioral determinants that come up in the exam room that are related to why patients are getting sick or having poor health outcomes. And we as physicians think, how can we go then into the community and make that better? And that is a very good question. The key insights, though, that come from this examination of medical culture and systems bring to light a few reflections that I've had over the years working in the intersection of medicine and public health. And that is that approaching public health work as a physician, even as an osteopathic physician, requires us to recognize that we are seen as an extension of the medical systems in which we work. And that can be a great privilege many times. We know that our advocacy can work on behalf of physicians and patients, but it can also have an underside. It can cause us to be cognizant that this dynamic can come across as bringing a punitive fear, blame, or shame culture into a community, especially a community that may be disenfranchised, and could leave participants feeling underwhelmed, especially after a service experience. So if we work to facilitate a different type of culture, then our intentionality about the experience changes and we have an opportunity to adopt a different stance in our work. So this is what we're talking about, moving from a blame and shame culture into what's called a just culture. And having that originate within the medical systems in which we work so that we can bring it into the communities and promote better health. So what is just culture? Just culture is defined as a middle ground between a punitive system, one that's based in fear, blame, and shame, into a system without accountability at all for actions or behavior. So those are two ends of the spectrum. Just culture meets those in the middle. It's not just culture, it's a culture based in justice. And that is where we hope to get to. Just culture examines systems. So in this picture, what we see here is that, where we talked about equality and equity as being important differentiators between the type of work that we do and the interventions that we do, a justice system would say, why is there a fence there in the first place? We should remove the fence because it's a barrier to access for any of the individuals who are looking. Maybe if we remove the fence, we wouldn't have to deal with propping up the participants in order to see. And that's the difference between an outreach model or an equity model and a justice model, which is to work on the systems and remove the systemic barriers. The American Medical Association published a report on the importance of language and communication as being an important bedrock of this work. And they talked about the narrative ecosystem as an important starting place. The reason why this is important is that the language that we use, as we've been talking about so far, is important in perpetuating these systems. So here is a depiction of what is called the narrative ecosystem. So how does this work? In any system, whether that be a clinic or a hospital or a community, there are messages that are sent on a daily basis, the way people talk to each other, the way that messages are sent out. And when those messages come through, participants in this culture develop stories about why messages are built, what they're trying to say, what may be behind them. From the story comes a narrative about what the organization's about and how the culture in that organization moves forward. And what develops after a long period of time is something called a deep narrative. And what the research has shown is that if we get to the deep narratives about why the words are formed the way that they are, why messages exist in the way that they do, we can actually start to dismantle structures and move toward justice systems. So I wanted to put up here a report from the American Public Health Association that has actually outlined 6 key principles for achieving health equity and just culture. And they come about really coming from the research that we kind of just reviewed. So I wanted to go through each one at a time. And the AROC and NJOPS is a great venue for sharing these lessons because, it really is thinking about it from a large system point of view. So the first is to be explicit and to use deliberate language by naming groups affected by disparities and inequities and then focusing work there. The second is to identify and effectively address racism in particular and racial implicit bias, and to specifically name racism as a social and behavioral determinant of health, because that is an important bedrock for changing the systems in which we practice. The third is to adopt a health in all policies approach, which is a call to the political systems to integrate health equity concepts into legislation and into policies that are moving forward, which in fact New Jersey has done. 4 is to create an internal organization-wide culture of equity. And this could be actually a whole lecture in and of itself, but it gets to that point of the narratives and the messages. There are actually a set of standards called the CLAS standards that many hospitals and organizations have adopted. Could be interesting standards for your organizations. The 5th is to respect and involve communities in health equity initiatives, and we'll get into this in a minute, but the goal here is to say it should not be the work of physicians only to go in and fix things and then to go out. it should be about forming partnerships to improve the health of communities. And then 6 is to measure and evaluate progress. So I want to tell the parable of peanut butter, which kind of brings to light these 6 concepts. So imagine this. Imagine that you've finished a day of clinic, and you've seen many patients that day, some of whom are uncontrolled, have uncontrolled diabetes or uncontrolled health problems. And as you're doing your notes, you think, you know, many of the patients who I saw just don't have access to protein sources. There's too much complex carbohydrates, too many sugary drinks. And I think that I'd like to give back to the community and make sure that the community has better protein sources. So, I go on to Amazon, and on Amazon it says, oh, buy $100 worth of peanut butter and get 50% off. And so, on a whim, because it's been a hard day and because we've seen a lot of patients say, okay, let's buy it and deliver it to the local food pantry. Everybody could use peanut butter. It's a great protein source. It's a great, delicious snack. And hit the delivery button and get it out and say, okay, this feels a lot better. Come to find out that the local food pantry has had a surplus of peanut butter. But what they really needed was jelly and bread. Because everybody's been sending them peanut butter and nobody's been sending them jelly and bread. And by sending that peanut butter, the problem has now just been made worse because they have way too much peanut butter on their hands and they don't know what to do. So the parable of the peanut butter differentiates important concepts in public health work. The difference between what's called a savior complex or a superhuman complex with allyship. And these are terms that I think are really important to learn. Savior complex or superhuman complex is this idea that an individual, it could be physicians as individuals with power and privilege in society, try to make a change based on an observation that they've found, but really the change isn't helping the end user, it's just making them feel better. Whereas allyship is when there's a commitment and a connection with the people who have a need, and the person who's in the position of improvement and in giving back does the work of actually trying to dismantle the systems and the reasons why the hardship is there in the first place. That starts with asking questions, and it continues with acknowledging and working on implicit bias. And it's a hard and difficult task to do every day, but it is the difference that often makes the difference in true public health work. So that leads us to this concept of what are the key components of just culture? How does a just culture look in an organization that does this well? Well, these are the key components. It starts with wellness. It starts with being honest and self-reflective about our intentions behind engaging in outreach and in community service, ensuring that we aren't engaging in that active saviorism, and that we can bring our full presence to the effort. Why would we want to do that? Because we need our full presence if we're coming from a place of wellness to actually listen to the needs of the community, not what we think is best, just based on what we're seeing, and search for those systemic factors, and then to seek out as many perspectives with a diversity of perspective, welcoming and inviting those who are experiencing the need to the decision-making table, and importantly, giving those individuals positions of power and decision-making. This is the difference here. This is a community engagement framework from the American Public Health Association that differentiates on the left what we call outreach to, on the right, true collaboration and shared leadership. So to begin to close, I wanted to tell some stories about COVID vaccination as an example of some of these concepts. So by May of 2021, we had reached the stage in the pandemic that all adults 18 years of age and older were eligible to receive the COVID-19 vaccine. However, vaccination rates for many communities did not match the burden of disease, and this was being looked at by individuals in public health positions and trying to understand why. Why was this happening and where were the problems? So as an example, Latinx populations in Colorado comprise 22% of the population, and yet 41% of COVID cases. How is that? How does that square? And 25% of COVID deaths, yet only 11% of vaccine recipients. Similarly, a Black population in Washington, D.C. comprised 46% of the population. However, 55% of COVID cases, 70% of COVID deaths, and only 40% of vaccine recipients. This is a graphic of the United States showing that when the vaccine priority phases were developed in each of the states, which of those states created priority phases for the highest risk medical conditions. And you can see that there was a major disparity between the states of the United States. In the light blue, it depicts only 4 to 6 of the 12 categories that were considered as high risk. And 12 is the darkest blue. Thankfully, New Jersey is in the darkest blue. But there was a huge disparity across the United States of who was being eligible for vaccine based on high-risk medical conditions. So we know that a disparity is there. We know that an inequity is there. So what would be an equitable response? The first would be prioritizing vaccination based on the highest health risk. A couple of examples. In Massachusetts, 20% of vaccines were actually allotted to those with higher vulnerability. In North Carolina, older adults in nursing homes and people with disabilities were included in the high-risk categories. Second, prioritizing vaccination based on locations most severely affected. So an example of this is in Washington, D.C. There was actually legislation that was put forward that prioritized vaccination to communities by zip code and by disease burden in that zip code. And then importantly, also building trust with communities. Here in New Jersey, there was a vaccine effort to bring vaccine into local communities at their request and in partnership with community leaders, and that actually led to great vaccine success within our state, which I think is something to be proud of. So the last paper that I want to review is a paper that was published in October of 2021 by the Graham Center and the Primary Care Coalition Primary Care Collaborative in Washington, D.C. This paper was very interesting because it looked at the combination of primary care, public health, and social determinants in the United States. So I'll walk through just quickly. There was a new metric that was developed called the Community Health Index, the CHI. It's a new measure that looked at 3 different components. The first was access to primary care. The second was the strength of public health factors in that community. And the third was the degree of social vulnerability and combined social assets in that community. And the combination of those 3 factors created a score that was a score between the lowest of 1 and the highest of 30. So a score of 1 meant there was low combination of these 3 factors. A score of 30 was the highest combination of these 3 factors. And the relationship between CHI, so this new Community Health Index, was then compared to 3 rates: vaccination rates, COVID-19 infection, and then COVID deaths. So the scores between 1 and 30 were divided into quintiles by county. And so quintile 1, quintile 1 was the quintile that had the lowest scoring counties. Quintile 5 had the highest scoring counties. And you can see here that the percent of the population represented by the lowest quintiles was 20%, of the highest was 17%. So here I want to show you a couple of graphs. The first here on the left is the Community Health Index distribution by county across the entire United States. So you can see the lightest blue was the lowest scoring counties, and the darkest blue was the highest scoring counties. Actually, in New Jersey is mostly dark blue, which is really great, and great for us, go New Jersey. But what I also want to show you here is a few slides about comparisons. So this graph shows the percentage of the adult population who received COVID-19 vaccinations by Community Health Index. So on the x-axis here, the higher the number is the higher the vaccination rate. On the y-axis, it goes backwards, where the lowest CHI is the lowest combination of these factors, the highest is down at the bottom. And what you can see here is a significant correlation between the percentage of vaccination in a county correlated with the highest CHI. So it was the combination of these factors that led to success. A couple more graphs that I want to show you. Here on the left is the number of COVID cases before and after the date of vaccination commencement, and on the right is the number of COVID deaths before and after vaccination commencement. So what do we see here? We see lowest CHI on the left, highest CHI on the right on both of these graphs. So the first thing that we see when we look at this graph is that COVID cases improved with vaccination. Every single quintile had an improvement in their COVID vaccine, their COVID cases rate and their COVID death rate after the COVID vaccine. But the other thing that was interesting was that you see a decrease in the amount of cases also as the CHI rises. So it focuses in on this point that it's not just these individual factors, but the combination of primary care, public health, and social factors. So these are the study conclusions. Vaccinations are effective in reducing COVID infection and death. This was one of the first studies that showed that. Second, access to vaccination is enhanced by the combination of these factors, and that it's important to recognize that the combination and the integration of these three factors is important to success. So the story of this COVID vaccination experience really brings to light an example of how we change the questions that we ask. And if we change the questions that we ask, we can get to answers that actually move toward health equity. These are some examples of reframing the question. Instead of asking, what interventions can address health disparities moving immediately to a fixing situation? Ask the question, what generates health inequity in the first place? How can we get to that fence and removing the barrier of the fence in order to allow access to everybody at the game? And there are many other questions as an example. Lessons learned and best practices from working in clinical medicine and public health. To promote health equity, really asking ourselves, has a community openly expressed a need, and what specific type of support has been requested? Trying to be self-reflective about the question, Am I providing the kind of help that is needed by the community, or am I operating on my own assumptions about what is needed? That would be a place where unpacking implicit bias is important, engaging in practices that actually dismantle systems of oppression and harm are important. These, to close, are principles for, so we learned about achieving health equity, now it's about sustaining health equity. How can we as osteopathic physicians sustain? Because it's a daily practice. And there are 4 strategies that have been outlined by these many reports that have been put out. The first is to think keenly. I love this quote, "Truth does not by itself resolve conflict. Only meaning does," right? It's not about finding out what's right. It's about making meaning for the participants that are engaging in the work. To listen deeply, which I know we all do as osteopathic physicians every day. To act intentionally, and then to reflect frequently, because it's that reflection that is so vitally important. We talk about this at the medical school and in training, is that we should always be learning more, asking more, and those are strategies that can move us forward as osteopathic physicians every day. So with that, thank you, and I hope you enjoy the rest of your evening and conference. I too would take any questions, or we can wrap up. Thank you so much.